And Kunal, are you ready? Should I?
I am when you are and everyone else is. I can go
Okay,
ahead.
great. We welcome Kunal Saxena, who is the Director of Vaccines at Merck, correct? Is that
Yes,
correct?
that is correct.
And he's going to talk to us today about HPV at age 9 initiation. All right, go ahead, Kunal.
Can you see two slides or one slide?
We can see both, so if you want to switch the display settings.
Yeah, Zoom is not letting me do that for some reason. Let me.
Looks like it might be right next to where you are. Right now you're on show taskbar. It looks like there's a display
Okay.
right
Yeah,
next to it.
there you go. Okay,
There we go. Thanks, Kunal.
perfect. Thank you. So thank you again for the invite and opportunity to present in this meeting. So I'm going to talk a little bit about our research that we've been doing over the last, I would say, 2.5 years. And this is a survey research where we want to assess the perceptions and beliefs and knowledge of parents and providers in the US around age 9 initiation. And I know, a couple of you have already done some survey research, published them, and that was what, we wanted to build upon that great research and also wanted to include parents along with providers to understand their beliefs and knowledge about, this topic. And the focus, there are multiple survey studies that you can see that we have done as part of this research. The first one is focusing exclusively on healthcare providers. And then the next phase, when we started, we wanted to talk to the parents of children who were, age 9 to 12, and wanted to ask them about the parental attitudes and preferences around initiation of HPV vaccine at age 9. However, along the way, we started hearing a lot of, comments around, whether age 9 is actually beneficial for people who would get the vaccine anyway at a later point, or could it actually increase the overall coverage by getting people who otherwise wouldn't get the vaccine for whatever reason? And that's an important question, right? I mean, because those are two different things. Some of those people, proponent of, or opponent of this strategy would say that, this is not making a difference because parents or providers would vaccinate those kids at like 12, 13, 14, even though there are benefits of getting them vaccinated early, but still, in terms of overall coverage, that's an important gap. So because of that question, we added another phase to the study, which is what I'm going to discuss today, the second sample. And here, we wanted to talk to those parents who were specifically either undecided or were not planning to get the HPV vaccine to their children. And we asked them a bunch of questions that determined that, yes, this was a sample that the parents were, either undecided and sort of more likely leaning towards not getting it, and people who have historically refused and were also planning to refuse in the future if the vaccine were to be offered to them. So we wanted to actually get to that question, through this survey study, and we thought it would be insightful, at least, to get the preferences and perceptions of those parents specifically to understand, if this strategy could work. So in interest of time, I know I only have 10 to 15 minutes. I'm going to move a little fast and only discuss the results of this objective. So this is, again, it was a cross-sectional descriptive study. We focused on the parents, or the sample of the parents who had at least one child that was age 11 to 12-year-old. Parents who were involved in vaccine decision-making of their child, had accompanied their children to at least one vaccination visit, planned to refuse vaccination for their children, or had not decided whether to accept the vaccine or not. And then again, all the other eligible criteria that would make sure that our sample is good for this objective. So now the results. This is just the patient characteristics, the mean age of the parent sample, and there were 200 in total. 100 were parents who were uncertain, 100 of them who were refusers. Mean age was around 39 years. 70% of the sample was female, so mothers. Education level, again, most of them had college degree, at least. Predominantly white, almost 86%. And then, whether they had received a dose of vaccine, and then what type of school school that the child attended. So these are some results around their current vaccine-related behaviors. So as you can see, parents who plan to refuse the vaccine for their children were more likely, reported that, having delayed a vaccine for the children. So again, any vaccine doesn't have to be HPV, but people who had refused the HPV vaccine were more likely to report having delayed a vaccine for their child. Significantly higher rates of receiving information from outside source was reported among parents who plan to refuse vaccination compared to people who were undecided. More parents in the undecided cohort, which is on the right, said that they try to follow recommendations closely compared to parents who plan to refuse the HPV vaccination for their children. So as you can see, 89% of undecided say that they at least try to follow the recommended schedule for the vaccine closely, whereas only 43% of the refusers said that they try to follow the vaccination schedule. Primary reason, we also asked them, we also probed them for the reasons that, they were not willing to get the HPV vaccine. And again, a lot of these, I would say most of these reasons are very well documented in published literature. So too many shots at the same visit. My healthcare provider hasn't mentioned it. Concern that it'll encourage my child to be sexually active, concern about side effects. So again, this was just to validate the sample that these are the parents, and the reasons that they are thinking about are the reasons that I think most of us are very well aware of. So now this is the main result of this phase of this from this sample. So parents in both groups indicated that had they been asked about the vaccine when their children were 9 or 10-year-old, they would have either definitely or probably have accepted. And I'm showing a table of just that question, and then the subsequent slide I'll go through some of the reasons. But at least this slide shows exactly their responses to this question. And as you can see, the overwhelmingly, at least 70% in both groups, actually would have said definitely yes or probably yes. I would want more information. And to me, that is like a very encouraging sign that it could, again, from based just on this sample, they could age 9 could actually get parents who otherwise wouldn't get the vaccine, could change their mind and get their children the HPV vaccination done, had the vaccine been offered at an earlier age. And as you can see, some of them were still uncertain, and some of them probably they would need more information. The undecided parents numerically were more likely to have said definitely yes, 52% versus 36%. But like I said, in both groups, almost more than 70% of the respondents would probably or definitely have accepted the vaccine had it been asked, at age 9 or 10. And then see, these are some of the top reasons. Again, there's a longer list than this, but I'm just projecting the topmost reasons that the parents gave. And as you can see, more than half of the parents in both cohorts reported knowing their child would need fewer injections at the 11 to 12-year-old visits would have factored in their decision. And majority of parents also reported that knowing vaccine would still be effective at an older age, even if given at age 9 or 10, would have helped with the decision making. And then again, some of the other reasons are listed on the bar chart here. But yes, a lot of these reasons again have been established in previous research. So just wanted to give a very quick snapshot of this second phase of our survey study. I know I only had like 10 minutes and I've probably taken more, but just want to plug in that these findings, along with the parental survey, the other parental survey and the healthcare provider survey, will be presented at the HPV national meeting in Indiana. And then we're also drafting the manuscript currently, and hopefully we want to get it published in the next few months. So I'll stop here, and I'm happy to answer any questions.
Thank you, Kunal. That is very encouraging data that you have. Does anyone have questions for Kunal? Sorry, I can't see everyone, so no.
I don't understand it. I mean, I guess you're saying that, I mean, it's a cool finding that if we moved to, so this, what I got was at age 9 to 10, these parents think that these parents who are like really truly hesitant or just downright hell no, would suddenly just flip over and be like, hurrah, this is great. I don't understand that part of it. And the reasons you gave are sort of make sense, sort of don't. I mean, having fewer doses, that seems credible, sort of. I guess I'm trying to get my head around it. Like, do you believe these findings? I'm like, I don't mind things being unintuitive. I like unintuitive things, but I don't quite get it. Like, where the psychology is in this. That's like, where's the smoking gun that's making all this work? I guess that's the thing I'm still puzzling over. I'd like it to be true, but I'm not sure I yet believe it.
No, that's a great question, and you're not the only one who's asking that question. I think when we looked at the data, a lot of us asked the same question, like what is sort of enabling them to change their mind. Certainly, could it just be the case that if things were to happen in the past, there was no way of knowing that their responses would have actually translated into those actions. But at least that's the nature of the survey study. But again, I think the reasons that they provided are credible, because some of the reasons they said, like and again, it's not on this slide, like the focus of the discussion will still be on cancer prevention and not sexual activity. Fewer injections at the 11-12 visits, and then some of the other ones. But yeah, I mean, that's what the data we have from this sample. And again, it's only 200 people. So based on this sample, that's what we got. Maybe if there's an opportunity to do like a bigger sort of sample in future, we can try to validate that. But I still think these are interesting data.
Sorry, I may have missed this, Kunal, but how did you recruit your sample?
So it was from an existing panel of survey. Sort of we use that panel through our vendor, and they sort of recruit the parents and providers from the panel. And again, they have to meet the screening criteria. So like we wanted to make it sort of somewhat nationally representative, but again, based on the baseline characteristics that you saw, we had sort of higher mothers in the sample, predominantly white, younger, 40 years mean age. But again, we recruited from a panel that is purely used for research studies.
Jen Conga?
Yeah, Melanie, you went kind of where I was going. Hi, Kunal. Thanks so much for sharing
Jen.
this. I was
Mhm.
curious too. I don't see like geographic makeup and insurance status, because I'm thinking through, oh, this is
Yeah.
seems information that would be helpful for us to share with healthcare providers, but the kind of the broader applicability, because as you just shared, it's very white. I'm assuming maybe pretty suburban with that college degree.
Right.
So just wondering, we're doing a lot of work right now with community health centers. So I'm thinking, like, how applicable would this be across the board to share with
We do
providers?
have geographical distribution, definitely. I can try to sort of send it after the call. I'll have to check whether we ask questions around the insurance status. We probably should have, but we definitely have the geographical makeup of the sample.
Gabby?
I was just this is Curious George over here. Did you ask any questions about external events or anything that may have prompted the change to be more open? Like, was there something that maybe an external event in their family, or maybe there's something that happened on the news, or something that they were exposed to? I guess like in some ways I'm
Yeah.
also interested in like, what was the cue? Like, what was
Well,
the cue all of a sudden to help shift
yeah.
to
I
9?
don't know if we probed much on external events. We definitely picked up a lot of questions from, like, the existing vaccines, HPV vaccination scales, especially the ones that Dr. Zimmett had developed because he was a collaborator on the study. So we definitely use those questions to understand, to get sort of a feeling of how the sample works and their beliefs and overall knowledge and attitudes and perception towards HPV vaccination. And then for the reasons of the their perceptions over age 9, we did probe them. We asked questions to the effect of, like, okay, what are some of the topmost factors, and select all that you could apply, or you can give us any other reasons that you don't see on the list. And those were the nature of questions we asked, and we did sort of go into some detail. And again, I'm not showing everything right now, but we have like a whole list of questions in that survey to probe that. I don't think we go into like okay, what extent, like COVID, for example, or anything related to that. I don't think we didn't want to confound that.
Yeah.
Yeah.
It's just, just curious because, sometimes the cues are so different. And sometimes there's no cues, right? Like, so.
Yeah, definitely. And it's an interesting finding. Like I said, it's a small sample of 200 parents, 100 uncertain, 100 not, refusers. But based on this sample, that's what the data we got. Again, this is, in no way representing the entire United States parental community's perceptions. But again, maybe we can sort of build upon that and try to do similar research on a bigger and a more diverse sample of parents and see where we land. But again, I think this is still like a step in the positive direction, at least in my opinion.
So saying in a different, I mean, sort of like the high level story here is that it's a possibility that the crowded adolescent platform is causing hesitant parents to reject the vaccine unnecessarily. Right. I like that. I mean, I don't think sort of maybe when you tell the story of this, you could start with something like that as a sort of like a research question or a hypothesis.
Right.
It might help frame all of this and make it easier to digest. Because when I hear it in those terms, it seems okay to me. And as on the screen that we're on, the second and fourth, no, the next screen, the second and fourth things about I don't know where you're going, but we're on the screen we were just on. The second and fourth sets of bars were essentially that story.
Okay. Yeah, this one I think you're saying.
Yeah.
Yeah.
Yeah, they're basically about too many vaccine doses at one visit. And I think there's something to that. We're investing in some of that and some parent research that we're working on.
Okay. And I like that idea, Dr. Brewer, a lot. Starting with the hypothesis, just sort of the sort of more background on the crowded 11 and 12 platform, and then try to sort of give the rationale, okay, why is this important? And maybe if the vaccine were to be offered separately or earlier than the other vaccine, then maybe there's a chance that parents will be more receptive to that. That's a good point.
So Jen Conga made a comment about potential issues with generalizability. Jen, did you want to say anything else about that? No.
I think I was just, I gotta go back. I'm like, where is my comment? Because I started looking at something else. No, I'm good. I'm good.
Okay.
What was the comment again? I think I can try to at least note it down.
Did I not put it in the group chat? I'm like,
okay.
Oh yeah. Because it was an online survey from like a research group, so that like their tendency to do an online survey versus going into my, community clinic and being asked to do something in the here and now, like
Sure.
How applicable is that representative of the broader population, I guess?
That's a great point. And like I said, I think again, this panel is not just made of like research people. It is used for research survey studies, but again, the panel represents, sort of general US parent population, if I can say, because they get sort of reimbursed for their time and everything. So they then agree to take the screener. And if they meet the selection criteria, then they're asked whether they would like to still go ahead and participate in the survey. So yeah, I think there's definitely components that may be limited to the sample, but then there are also components that will be generalizable to the US population. And similarly, like, the sample you're talking about, people who come in for clinics or like, routine checkups, that could also have some sort of limitation because it's like a convenient sample. So again, it's hard to sort of get that perfect sample, but again,
makes
we have
sense.
to sort of acknowledge the limitations and just move forward with that.
Thank you, Kunal. Sherry has a question about demographic data. She's wondering if you have anything about religious affiliation for the sample.
I think we did ask a question on religious or political ideology. I'll have to go and check, but we did ask a question on that. Yes.
Yeah, that would be interesting to see.
Yes.
Any other questions for Kunal? All right. Well, we really appreciate. Oh, go ahead.
I was just saying, I'm sort of mulling over what Noel said earlier, that I can see where for the undecided patients or the parents, and you say, well, what if we'd asked you before, or this idea of spacing it out, they can actually give a real response. But for parents who are saying, or the response is really believable because they're still making their decision. But for parents who said like, no, we're not doing it. But sure, if you'd asked me before, I would have said yes. But
Yes.
I'm saying no now, and I'm saying no for the future. That's, I think, this a little bit of a disconnect. Like, well, why would you have said yes before, but not now? That's kind of interesting to me. But I do think that parents really like to have choice in the matter. And I do feel like with the adolescent bundle, it feels like so much pressure to get them all done at the same time. They've got a kid who's whining about it. They have their own concerns around safety. And just then they're busy and they don't have time to come back. Like, so they push something off and don't have time to come back for it. So I do think the idea of giving them some choice and how they want to space it out, parents really do like that. And they also do like not talking about sex. They like, a lot of times at 9, they're thrilled to be able to talk about this in code and not talk about sex. It's quite interesting. Some will talk about it and say, hey, isn't it sexually transmitted? And then you're like, okay, that's my cue that this parent does want to talk about sex. It's just very interesting, but they love not talking about sex at age 9.
Right. And I agree with all the comments you made, Dr. Zahn. I think, the one that you made earlier is very true because, again, like I said, I think because of the nature of this research, it's hard to sort of go back and see whether these responses would have translated into the action that they're saying. But again, that's at least a perception. And it's going to be hard to sort of know that unless we sort of follow these people over a period of like, I don't know, 10, 15 years to see whether they actually, parents who say that they will do it if, the vaccine were to be offered at age 9, they actually do it or not. It's just going to be hard to sort of determine that. So again, instead of that, this is at least giving us some sort of insight in an indirect way. And like I said, I think this is just sort of one of the first smaller sample study. We're still trying to figure out like if we get a real world data study or try to do some sort of a community-based prospective trial where we can follow parents and children over a period of time. But again, for now, I think these are the data that I thought was interesting to share with this group. And again, very good feedback. Appreciate everyone's comments, and we'll try to incorporate more. And then when we present these data in the future forums, I'll try to see if we can get more details on the sample and all the other reasoning that they gave in their beliefs and knowledge questionnaire, so it can be a little more comprehensive.
Thank you, Kunal. That's, really, thank you for taking the time to talk with us today and share your findings. It's very interesting.
Sure, thank you for the opportunity.
Thank you.
Okay, so next up on our agenda is a discussion of best practices bylaws. And we're going to vote on it. And I think Gabby is leading that discussion because Heather couldn't join us today.
Yeah, I was voluntold that I was leading. Yeah, voluntold. So you guys got the email, so I'll go ahead and share my screen. Am I sharing the right screen? Can you see it? Oh, okay. So for those of us who have older eyes, I kind of zoomed in a little bit, but I don't want to scare you. So I think the last time we brought up the discussion about the bylaws, a lot of the discussion really was centered around the diversity of membership. So I'm not going to spend too much time around the language with the task group itself and who we are, the charge of it, unless you guys want me to, and we can go paragraph by paragraph. But I'd also know there was a amendment to the committees, the description of the committee. So you'll see that she has a proposed amendment as of January 2025 that the steering committee under the HPV Roundtable will appoint task groups and committees to implement roundtable projects, which we understand is a part of our bylaws overall. And that specifically the best practice task group, the description of our charge is focused on best practices and emerging practices to increase HPV vaccination coverage. I believe that this was not where we had a lot of discussion last time, if my memory serves me correctly. It was really around the membership, specifically the number of members, and how those members will be chosen. But we've agreed, however, in leadership, yes, Conga?
Finish what you're gonna say, then come to me.
No, go ahead.
I was going to chime in. I read through this before the call, and Noel, I want to call on you to back me up on this. Just from a historical perspective, the best practice task group, one of the elements that I didn't see included here that I just wanted to have dialogue about was this was kind of always the group that included some of the national leaders of national public health organizations, academics, and leaders of national organizations such as AIM and ERA because of their breadth. And I think as the diversity of and representation of the roundtable has grown to include, more state level organizations and regional, and in some cases individual organizations, I just wanted to raise that, Gabby, is because it's had a limited size. I just wanted to bring that up for discussion. And Noel, since you've been here since the outset, what would you add to that?
I mean, part of what got it going was it was a place to get scholars involved. So research scientists have no role in the roundtable because they don't represent organizations for the most part. They just are out there doing research and they know a lot, but they're different than someone who's the head of AIM or the head of AAP or whoever is tasked from AAP to come spend time with us. And so for that reason, we wanted to have a place to get their smarts and then also how to bring what academics know or are learning or can know to the roundtable. So that was one of the core functions. So that addresses a corner of what you said, Jen. The other thing I don't see here is that this is in the U.S. and I maybe it's implicit because our entire roundtable is in the U.S. But we could, in that first sentence, add the word in the U.S., the phrase in the U.S. at the end of the very first sentence, if that's what we really are.
So which first sentence further up or in the charge?
1A charge, the best practices task group is charged with identifying and showcasing. Yeah, right there.
Okay.
And I guess I'll say one last thing is that I put a lot of effort into editing this, I think 3 times, mostly to get the structure right. And I love it starting with a chart. I think it's really helpful. I then like having the leadership because there's a lot going on with leadership, and then you have the membership. So I think the structure is one that probably the roundtable should use in other documents as well for other groups. So I think there's some value there. That said, I've seen it so often and said so much already in it. I think it's functional and good. And I also saw Heather's comment that we've been looking at it for 3/4
We've
of a
been looking
year.
at it too long.
It was nicer than that, but yeah, I like the idea of us finding a way to, whatever concerns we have, let's find a way to address it at this meeting and come to approval of this by the end
So
of the
Congress, just thank you for bringing it up, and Noel, thank you for providing a historical insight as well. And so it's my understanding that we need to at least call out that this is a group that's comprised of national thought leaders, experts, subject matter expertise, and academics, which I think is completely fine. And I think it's also going to be helpful because when we have conversations about people who want to join, we constantly say like it's a different group, and it's a different group because of that reason, right? And so yeah, including it I think could be helpful. So I'll just include that as a comment. So last year, the roundtable kind of instituted the chair-elect dyad role to the roundtable, to all of our task groups is kind of where we're moving, so that when the chair rotates off, then the chair-elect will kind of serve. And that's what we did with Heather and Melanie. And so the leadership just talks about that the chair will serve a 1-year term. When the chair completes it, they will serve as an immediate past chair, and then the chair-elect will serve a 1-year term, and then they will rotate up to a chair. And I don't think that there was too many points of feedback, but is this an area where you see any amendments or any other additional changes that need to be made concerning the leadership descriptions? KO?
Hi, no, one thought is as much flexibility as we can allow would be good too. Like, what if nobody else wants to be a chair and somebody else agrees to do it for 2 years? Like, I want to allow, it's a lot of turnover in a sense. And not everybody always wants to take that much ownership over something, in my experience.
Maybe we could say at minimum.
Or 1 to 2 or something that just gives a little more room for, because what happens if, I don't know, if there's nobody else
I
and
think
that
at
person's willing to
minimum-
do it.
Could we say like with the option to extend?
Or renew, with an option to renew.
Yeah.
That'd be good.
So glad for autocorrect.
Do we want to limit the number of renewals so we don't have an oligarchy?
I think we said like 2, 6, 2.
Abby, what is the language for the co-chairs of the actual roundtable? And do you want to align it with it at all?
Yeah, I'll have to go look at the bylaws, which the bylaws are going to change anyway. But currently that's the ACS. They're changing all our bylaws. But currently is our co-chairs for our roundtable are 2-year terms, which is renewable for only 2 consecutive terms. So I'll make sure that this is consistent with how that's stated for this section. But thank you for that suggestion. KO, thank you for that too. Any other comments or points of feedback for the leadership section? Okay. Members. So it talks about the task group having no fewer than 12 members. And I believe we did a lot of email dialogue, but not setting a max for a reason. Members can come from the constituent groups of the roundtable, supplemented by subject matter experts. Congress is where we need to add it, or do we keep it earlier up? Concerning diversity of membership type.
I think in the charge would be my suggestion.
Okay.
Quick question. How many members do we have now? Out of curiosity, I just have no idea.
I believe we're somewhere between 12 and 14.
Okay. And what happens if we have fewer than 12? If we say we have to have a minimum of 12, do we have to go hunting for some? I just don't know is there flexibility around that language too? I should have been a lawyer. I might still have a job.
Yeah. You still have a job.
I do.
Currently it's been, I believe, like an invite if we have I don't even know if anyone has really paid attention to the number, to be honest with you. At least we
Right.
haven't since when Debbie was here. We didn't pay attention. It was more so like who's been active, they haven't been active, so let's rotate them off
Yeah.
and make sure we have somebody else from that key group to be engaged. So that's kind of how it's been historically. Do you
I
think,
don't know. I like a little more flexibility. That's all.
I know.
If we have 11 and it's a grade 11, do we have to, throw another person on who may or may not want to be there? But if we think we're always going to hit 12, then that's fine.
I think 12 is going to be a great baseline for
Okay.
this group. I think previously, wasn't the previous iteration had a range? Wasn't it a range? I've gotten lost with the emails. And I believe that there was a conversation of not having a range. So do you want to just keep it as a standing 12? Should it be
That's
a 10
fine.
to 12? Should it be a 10 to 15? I'm happy I'm flexible with what this group wants to move forward with.
I would say just keep it at a minimum of 12.
Okay.
That allows flexibility on the upper end at least.
Okay. They may be invited to join or self-nominate. Interested individuals should submit interest to the roundtable staff for consideration, and composition of members is based on the current and future HPV Roundtable and best practice task group priorities and subject matter expertise. Any changes with that section or area?
I just want to address Kristen's concern really quickly about the 12 minimum. I think really what that does, Kristen, is it puts an impetus on us to identify potential members if we get below 12. So it's not like anything terrible happens, but it gives us the push to reach out, right?
Yeah, no, that sounds good.
Some new blood.
Yeah, exactly. Sorry, Gabby, go ahead.
No, you're fine. The term of the office for members is a 3-year renewable term. So you guys can serve for 3 consecutive 3-year terms. So you can be on this thing for up to 9 years if you want to. If I did the math correctly, and if I didn't, just ignore me. And a former member becomes eligible for reconsideration after rotating off for a year, and then they can rejoin. So, I mean, I think that's pretty solid in itself. That's a lot of bandwidth. Members are expected to attend 75% of meetings annually unless absences are otherwise approved of by the chair. Meetings are held monthly or at the discretion of the chair, and members should contribute to meetings, provide feedback, and share information. Any changes concerning the terms of members on the best practice task group?
Nope.
And then what about yes, Sherry?
Oh, when we're sort of done with that, I want to back up to the leadership section. So finish.
Okay. What about the attendance and engagement section? No's over it. He said, I didn't look at this damn document too many times. So y'all have a conversation. Any suggestions, feedback, objections, changes? Okay. So yes? No? Okay. Leadership, Sherry?
Yeah, I'm just wondering, it says they're appointed, that the leader will be, or the chair will be appointed by the executive committee, but do we want to have a process for how the next leaders are identified or nominated or self-nominated? What do we need more on there, or does it need to, should it stay broader?
So the executive committee is the chairs
Of the roundtable, the
of the
co-chairs?
roundtable. Isn't that, we had a discussion about that, right, last time? I think Perkins was trying to clarify who's the executive. I think it's the chairs. Bob, when you were appointed as chair, were you appointed by the chairs of the roundtable?
Yeah, I think I was just kind of But I think there was just kind of a sense of like, hey, do you want to do this? And that was sort of how it happened.
And I remember even with Heather, I don't know if there was an appointment by the executive committee. It was just a, hey, we think you'd be a good fit. Are you interested? Same with Melanie. Hey, you would be a good fit. Are you interested? So I think we could remove the executive committee piece of it off, but I want to make sure it's consensus with that decision. Because I don't believe
it is
previously.
you could say the chairs, but it is the chairs of the roundtable who make the call. They appoint whoever's going to lead these things, and it's through a somewhat informal process. Like I'll acknowledge that, but
Maybe it's
and also
lax.
honestly, the staff are the ones who are paying attention. They're like, I noticed this person doing whatever. What about this? That's often how it goes. So the tri-chair, whoever the ACS third chair is, that person is the person. So Debbie basically was the person who's making suggestions previously.
I think they're not going to do it without sort of the consensus of the task group anyway, right? I'm not worried about sort of a rogue executive committee situation of appointing.
Well, I don't know if it's an appointment. I think it's more of an approval than an appointment.
I've never seen any discussion, or I don't recall discussion in this meeting about who should be our chair.
Yeah.
That's something our committee has done.
Okay.
And does it say here that they actually have to be on the task group?
No.
I mean, it seems obvious that they should be a member of the task group. It says they have to be in good standing at the round table and 2 years experience with the round table, but could like literally we have a completely new chair just pop in who's never been on our
No.
committee?
If there was I mean, if no one else wanted to do it and somebody else really did and they'd been, you know what I mean? I could see, again, I'm sort of for most amount of flexibility. That, I don't know. I think it'd be okay.
Well, let's have a vote or discussion about that. Should it be an existing, should you already be integrated task group? Or should the group be open to bringing someone completely new?
Because you have the chair-elect. So by definition, the chair-elect has been there and is ready to take on. So the new chair-elect could, in theory, be somebody who hadn't been on the committee before, but then they spend a year on the committee before they're the chair.
So you're saying the chair-elect could be someone that's not been engaged, but the chair has to be someone who is already engaged.
Sure, because the chair was the chair-elect the year before. That's how it was written, right? So I think in that scenario, the way it's written now, you wouldn't come in as chair with no experience on the committee because you were the chair-elect for a year on the task group already, right? So I think we're safe
Makes
there.
sense. I do have one question though with the chair and the chair-elect. With the option to renew the term for the chair, you say the chair-elect, the end sentence in B2, the last sentence, the chair-elect serves a 1-year term in that role and becomes chair upon completion. But are the chair and the chair-elect selected at the same time? And if the chair is renewed for a second year,
They also would be renewed.
Right.
Yeah. Yeah.
So we could give the option of the chair-elect to, decline to renew their term and then bring in a new chair-elect. Or give them the option to renew as well.
We have to decide, do we want this to be a 1-year thing or a 2-year thing? And that's not clear. What I'm seeing here right now is shifting from a 1-year to a 2-year. And that's fine if we want to do that. My observation is that after a year, people are done with it. Like, it's a lot. For whatever reason, like, we're a very effective committee. It's also tiring on top of other people's, academic jobs. So we just want to take some care that this option to renew is an optional thing, or it's a rare thing, or whatever we do. Or we just say we really are looking for 2 years because we want the stability and there's something strategic about it. But it seems like 1 year works.
I see Cynthia nodding the head, yeah. So it sounds like you're in agreement with the 1 year.
Yeah, I think I totally agree with Noel. I think with everybody having full-time jobs, committing to 2 years is a little bit more of a challenge. I understand the option of a second year. I don't know that people liked to be like, all right, no one else is willing to step up, but they're willing to do it if need be. But that's just kind of implied. You know, ideally, you're able to, you know, step in here, you know, that's why you have kind of an incoming, the chair-elect position. I don't know that a chair-elect wants to wait 2 years to take a position either.
Correct. Shelley Fiskus?
Yeah, I agree. I think it really is it's a 2-year commitment as written. You commit.
Yeah, because you're a chair
chair-elect,
and then
you
you're a
commit.
past chair. You're chair-elect and then you're chair. Yeah.
And that's, you know, a lot of other organizations do that, you know, state level AAP, national AAP, it's a, you know, president-elect, president 2-year deal. I think that's good.
So if I'm hearing based upon the consensus on this call, you okay with me deleting everything I just typed in? I just want to make sure we're good with me deleting the renewal language next to the chair in the chair-elect section. I do think in my opinion, it's gonna get a little vague and messy. And we may have KO that someone does want to stay in for longer.
I don't feel that strongly. Let's just
Yeah,
plow ahead. We have to get this done or Heather will never forgive us.
please. I do not
We
want to.
cannot bring this to another meeting, so.
Please. Okay. Anything else you see as potential changes to this document? I don't think that we're ready for a vote. I think I can send these comments back and then she can facilitate a vote. She's not gonna like it, but she can facilitate a vote via email.
Let's vote now. I'm ready to
Okay.
vote. And you
Let's
can
vote now.
do what you want with it. I favor them. Let's adopt them.
I
agree.
second.
Unanimous. Everyone just wants to be done with this damn document.
So Gabby, how do you want us to vote? Do you want people to like put a comment in the chat or?
We could do a thumbs up. Anyone in favor or yay? Thumbs up. Physical, thumbs up. That's unanimous to me.
All right, great.
I'll turn it back over to Melanie. Thank
And
you,
a
guys.
big thank you to Heather for helping us
Mhm.
get to this really outstanding document that reflects our practices, is flexible, has a lot of strengths to it. So it's been worth investing in.
Yeah. So Heather, if you listen to this recording on behalf of Task, thank you.
Okay, we only have 4 minutes left. So can we stop the recording?
Yeah, I'll go ahead and do that.